Hi, my name is Emily and I'm a nursing student at the University of Michigan School of Nursing. I'm going to present patient ES to you today. ES is an intelligent 16-year-old Asian female. Her former occupation and current occupation is primarily a student. ES is not married and resides with her sister and parents. Onset of the disease is unclear, but due to a concern of patient's mother that ES had pale and jaundiced skin tone of face and cheeks, as well as lack of appetite, patient had blood drawn during a routine physical on June 13, 2011. Following the blood draw at IHA by her pediatrician, a stool sample was then collected to gather more health information before treatment. On June 16, 2011, patient was immediately directed to the emergency room of DMC Children's Hospital of Michigan, as patient's hemoglobin was dangerously low at 4.5 grams per deciliter. The stool sample collected also indicated blood loss through the GI. There was serious urgency in her transfer, as the hemoglobin of children is normally between 11 and 13 grams per deciliter. The patient's hemoglobin was so low that doctors were recorded to be baffled that patient was conscious at such a hemoglobin level. At the DMC Children's Hospital, the patient was given blood transfusions in order to raise her hemoglobin to an appropriate level before undergoing an EGD with biopsy as well as sigmoidoscopy with biopsy. Soon after, patient was also tested for allergies to narrow down reasons for her anemia. Following the procedure, patient was diagnosed with vitamin D deficiency, anemia caused by gastritis, and collagenous gastritis. The locations of illness are in the abdominal region due to the collagenous gastritis, and the duration is unclear, but the outward signs of jaundice and lack of appetite were constant. During her time of diagnosis, it was regarded to be severe. Upon discharge on June 19, 2011, patient was carefully monitored through frequent blood draws and stool sample collections, along with occasional EGDs and sigmoidoscopies to maintain her health. Patient was also instructed to take orally 160 milligrams of ferrous sulfate supplement daily, vitamin D3 1000 IU daily, and in cases of constipation to take 17 grams of Miralax with a liquid to help pass stool without any bleeding or constipation. The diet of the patient was also altered slightly to include more naturally iron-rich foods, such as red meats and dark leafy greens. She tried to eliminate foods that are abrasive towards her stomach. Dairy was also encouraged to alleviate the vitamin D deficiency. Soon after, patient was transferred to the University of Michigan Hospital Pediatric Gastroenterology to continue care. Though patient was largely unaware of any problems around 2011, patient remembers being pale, not being hungry, and becoming dizzy with physical exertion. Patient reports being unaware of any pain, aside from when being constipated and passing a hard lumpy stool, which caused a pain rated 2 out of 10. Patient states that the anemia, vitamin D deficiency, and collagenous gastritis had not significantly affected her activities of daily living, aside from making her tire more easily from sports and being unable to eat well. However, when menarche was reached at age 13, the monthly loss of blood was considered a possible aggravating factor. Alleviating factors included taking medications as prescribed, avoiding foods that are abrasive to the stomach, eating foods that are iron and vitamin D rich, as well as being well hydrated. Currently, patient reports little to no concern about her health issues. She makes regular visits with gastroenterologists to keep things in check. With the help of her parents, ES maintains a healthy diet along with the vitamin D and iron supplements. On her last appointment, patient had a recorded hemoglobin of 13.1 grams per deciliter, but is still working on her vitamin D levels. There are still papules from collagenous gastritis present in her stomach. There was never a known precipitating event, and the case of collagenous gastritis is still not well understood. There are few associated symptoms currently, aside from the infrequent constipation. Vitals. In a recent vitals assessment, ES is 16 years old with a height of 160 centimeters and weight of 48.44 kilograms. Her BMI is 18.9, which is in the normal range. Her blood pressure was recorded to be 90/60, and her temperature was approximately 37.11 degrees Celsius, taken temporally. Her pulse was 86 beats per minute, and her respiration was 22 breaths per minute. Medical history. Childhood illness of bronchitis in 2001, Patient was also diagnosed with myopia in 2011 and now uses both contact lenses and glasses. Other injuries include fracture of fibula in 2012 and fracture of wrist in 2014. In addition, patient was diagnosed with collagenous gastritis, anemia, and vitamin D deficiency in 2011. Patient has no known history of psychological illness. Immunizations. Patient is up to date on all vaccinations and plans to get the flu vaccine in the fall. Allergies. Patient has no drug allergies, latex allergies, or food allergies. Patient reports mild seasonal allergies due to pollen or grass, with symptoms such as sneezing and runny nose. Past surgical history. Past surgical history includes an ER stay for EGD and sigmoidoscopy, casting of fractured fibula in 2012 during a ski trip, an MRI, EGD, and colonoscopy in 2013, and casting of fractured wrist in 2014 due to a slip on ice, and a most recent EGD with biopsy in 2017. Medications. Medications include vitamin D3 2000 IU orally, 2 times a day, ferrous sulfate 65 milligrams, 3 times a day orally, Miralax 17 grams orally with liquid in the case of constipation. Functional assessment. Patient reports no drug use, no alcohol use, and no smoking. Patient exercises 3 times a week, either through walking or running. In terms of rest and sleep patterns, patient gets an average of 8 hours each night and takes a nap if she feels tired. Patient is careful with nutrition and tries to eat a balanced organic diet with an emphasis on fiber, protein, and iron. There are no reported weight loss or weight gains out of the normal, and her energy is generally level. Patient does not drink any caffeinated beverages. Some safety devices that she uses include seatbelt, toothbrush, and sunglasses. Psychosocial. Patient lives with parents and sister and reports that it is a loving home. She has close friends who support her, and she is generally well liked. Perceived stressors currently include college applications and schoolwork that take up much of her time. Some coping mechanisms include music and watching movies with family. The only environmental stressor is learning to drive a car. Spiritually, she attends church and youth group weekly and identifies as Southern Baptist, all of which is very important to her. Educational level, she is a high school senior and is looking forward to college. Patterns of healthcare are regular, and with the help of her parents, she is learning to take care of herself well. She has regular appointments with her dentist, optometrist, gastroenterologist, and her pediatrician to ensure that she is staying healthy. Family history. Mother of patient has a history of gingivitis and a complete thyroidectomy. Father of patient has high cholesterol and benign cysts. Sister of patient has anemia, VSD, and aortic stenosis resulting in heart murmur. Maternal side grandmother contracted hepatitis C from blood transfusion, which developed into fatal liver cancer along with OCD. Paternal side grandfather died of pneumonia, and there are several incidences of OCD and hoarding in aunts and uncles. Aside from these cases, all other relatives are long living. There is no family history of celiac disease, Crohn's disease, or ulcerative colitis. Abdominal. Given patient's diagnosis of collagenous gastritis affecting the stomach, it is important to conduct an abdominal assessment to maintain the health of her GI. Patient reports no change in appetite and only slight normal weight gain of 2 pounds in the last year. It was unintentional. Her bowel habits are easily affected by her food and fluid intake, and she has bowel movements normally once every day. The shape is normally long and color is dark, nearing black due to the iron supplement. No reported gas or bloating, and her appetite has been excellent. No nausea or vomiting either. No gum bleeding or indigestion, but infrequent constipation from either collagenous gastritis or stress. There is no abdominal pain or abnormal eating patterns. Patient describes stress levels as a 6 out of 10. She copes well through music and movies. During physical assessment of the abdomen, patient had even skin tones and flat contour of abdomen. Her umbilicus was symmetrical and lacked bulges or masses. No movement or surface motion was detected at the surface, nor were there any lesions and scars from past procedures. By auscultating the abdomen in each quadrant for a minute, normal bowel sounds were heard every 5 to 7 seconds. The vascular sounds at the aortic area, renal area, and iliac areas were also normal. No bruits or vascular turbulence. Palpation of the abdomen yielded normal findings. There is no tenderness through surface and deep palpation of the four quadrants. The aortic pulse was faint but not abnormal. In addition, the patient was examined for peritonitis and appendicitis, and through a conduction of the iliopsoas test, obturator test, and Blumberg sign, all were negative for pain or tenderness, indicating that there is no irritation in those areas. Cardiovascular. Given the patient's diagnosis of anemia, it is important to inspect the effects of decreased blood viscosity on the heart. Patient reports that she feels well and has constant supply of energy for activities of daily living. There is no familial history of cardiovascular disease either. Patient has no diagnosis of cardiovascular disease, but her anemia could cause the emergence of heart murmurs. She has not contracted rheumatic fever, viral illness, endocarditis, or pericarditis. There are no symptoms of cardiovascular disease aside from previous loss of appetite. ES has a regular diet that is proportional to her body size, as she does not feel a need to keep track of her carbohydrates, fat, and protein, but has a relatively healthy diet with lots of fruit, vegetables, proteins, and dairy. She takes only iron and vitamin D supplements daily. She is still menstruating. Her present occupation is a high school student. For the physical assessment of the cardiovascular system, a preliminary inspection of the patient's aortic, pulmonic, Erb's point, tricuspid, and mitral areas yielded no heaves or lifts. The contour of her chest is normal and symmetrical. Palpation of the same areas for lifts and thrills was also normal, and the PMI was found for apical pulse easily. Auscultation of heart sounds for the 5 areas for 3 to 5 seconds was normal. A strong, clear heartbeat consisting of S1 and S2 could be heard in each area. This was true when using the bell and diaphragm when she was both sitting upright and lying supine. There were no abnormal sounds such as heart murmur from anemia, S3, or S4 when patient was lying on her left laterally listening with the bell. Pertinent system number 1 is musculoskeletal. Patient was diagnosed with vitamin D deficiency, which could have serious adverse effects on the patient's musculoskeletal structure, though vitamin D is commonly associated with aiding the absorption of calcium to create strong bones. It has been linked also with an impact on the muscles of the body as well. According to a recent study by Therapeutic Advances in Musculoskeletal Disease, it is important to assess the musculoskeletal system because vitamin D prevents soft tissue pain as well as sarcopenia, which contributes to poor muscle function. Several studies have been conducted, especially in the elderly, where a meta-analysis of 26 trials and 45,782 participants came to the conclusion that vitamin D supplementation combined with calcium reduces the risk of falls, especially in those who are deficient at baseline. Overall, an insufficiency in vitamin D has been linked to low muscle mass and less muscular control. In a study of Saudi Arabian women who are veiled and heavily covered while outdoors, most developed proximal muscle weakness that is reversible with vitamin D supplementation. Therefore, it is very important to prevent such hazards with frequent examinations of the musculoskeletal system. Pertinent system number 2 is genitourinary. Patient has been on ferrous sulfate supplements for nearly 7 years, and studies have shown that anemia may have adverse effects on sexual performance of women. Although patient is not yet sexually active, it may become a concern as she develops. According to a recent article by the Journal of Sexual Medicine, iron deficiency anemia may cause anxiety in women, leading to poor sexual functions. Thus, it is important to assess the genitourinary system for any of such impacts. In a sample of 207 women with a median age of 33.6 years, women were given the Beck Anxiety Inventory, Female Sexual Function Index, and Quality of Life questionnaires before and after treatment of anemia. Following the treatment, there was a statistically significant difference between pre- and post-treatment scores of hemoglobin, hematocrit, serum iron, and serum iron binding capacity. Both the Beck Anxiety Inventory and the Female Sexual Function Index showed positive correlation following treatment, while the Quality of Life questionnaire demonstrated no difference. In the future, the patient may consider continuing her iron supplements in order to have more fulfilling sexual experiences. Therefore, it is also important to conduct a genitourinary exam.